All right, let's talk about urinary tract infections, or UTIs. Urinary tract infections typically begin in the bladder, where they cause cystitis, an inflammatory response affecting the bladder lining. If the infection progresses upward through the urinary tract, bacteria can reach the kidneys and lead to pyelonephritis, a more severe infection involving inflammation of the renal tissue. Otherwise, if it goes downward, it can cause prostatitis and urethritis, which are the inflammation of the prostate and the urethra. These infections are divided into two main categories: complicated and uncomplicated. A complicated UTI appears in populations with high-risk comorbidities, such as diabetes, or in physiological conditions including pregnancy. It also includes immunocompromised patients or those with long-term urinary catheterization in hospitalized patients. Clinical manifestations show signs of systemic involvement, such as fever, chills, vomiting, abdominal pain or tenderness over the costovertebral angle. They have a more severe course, with a higher risk of developing pyelonephritis, sepsis, and acute kidney injury. However, uncomplicated UTIs are usually limited to the urinary bladder and tend to have a milder clinical picture. Usually, patients present with burning or painful urination, along with suprapubic discomfort, frequent urination, urgency, occasional incontinence, and the presence of blood in the urine, also known as hematuria. So, how do we diagnose an UTI? A dipstick urinalysis can check for nitrites, which indicate nitrate-reducing bacteria, most notably gram-negative organisms like E. coli. The detection of nitrites strongly suggests infection. The test also measures leukocyte esterase, which reflects the presence of white blood cells. Although small amounts of leukocytes may be normal, elevated levels point toward infection or inflammation. Nitrites generally provide a more reliable indication of infection than leukocytes alone. Red blood cells in the urine signify hematuria. When blood is only detected on dipstick testing, it is referred to as microscopic hematuria. When visible to the naked eye, it is called macroscopic hematuria. Although hematuria is common in UTIs, it can also indicate other conditions such as bladder tumors or glomerulonephritis. If nitrites are present, or if leukocytes and red blood cells appear together, a UTI is likely. Treatment is usually warranted in these cases. If leukocytes are the only abnormal finding, treatment should be based on the clinical symptoms rather than the dipstick result alone. Sending a midstream urine sample for microscopy, culture, and sensitivity testing can confirm the infecting organism and guide antibiotic selection. Here's a pro tip for you. A useful way I remember all the key features of a lower urinary tract infection is by using the mnemonic UNHELD, which stands for urgency, nitrites, hematuria, E. coli, leukocytes, and dysuria. So, what actually causes an UTI? UTIs occur far more frequently in women because the shorter female urethra allows bacteria to reach the bladder more easily. Most uropathogens originate from the gastrointestinal tract, with Escherichia coli being the most common organism capable of easily reaching the urethral opening. Factors such as urinary incontinence or inadequate hygiene can further promote bacterial spread. Other pathogens that may cause UTIs include Klebsiella pneumoniae, Enterococcus species, Pseudomonas aeruginosa, Staphylococcus saprophyticus, and in some cases, the fungal organism Candida albicans, especially in immunocompromised or catheterized patients. Antibiotic choices depend on local resistance patterns. Trimethoprim is frequently used in primary care, typically for 3 days, though resistance can be high. Nitrofurantoin is another common option, but should be avoided in patients with reduced kidney function, particularly when the eGFR is below 45 milliliters per minute. Other alternatives include pivmecillinum, amoxicillin, and cephalexin. Cultures are not recommended unless treatment fails. Now let's talk about a special case, particularly pregnancy, where UTIs carry increased risks of developing pyelonephritis and urosepsis. Therefore, urinalysis is routinely performed, and if acute cystitis is suspected, it should be considered a complicated UTI and treated appropriately. The usual treatment approach involves nitrofurantoin or amoxicillin, followed by urine cultures to confirm resolution. With that being said, we'll wrap up the video here. I hope you enjoyed it and that you found it helpful, and if you did, feel free to leave a like or a comment. All feedback is really appreciated. Don't forget to subscribe, and I'll see you in the next one.